A very warm welcome to another episode of Today's Parent, where we endeavor to give you information that will make your parenting journey a bit more easier and connect you with experts. You have been sending a lot of questions when it comes to matters reproductive health. And in studio today, we have Dr. Monda, who's a gynecologist, who's going to answer those questions that you've been sending. Welcome to the show. Dr. Monda, so lovely to have you again.
Thank you. Thank you for having me.
Really nice to have you. We've had these questions that our viewers have been sending. So today we are going to have a pure Q&A show.
Okay.
So the first question that came in was about an implant. So her question is, I have been using an implant and when I removed it, it's been 9 months without getting pregnant. Anything I can do? What can she do?
Now, Christine, there's a lot of wrong information, misconceptions and myths about contraception, particularly hormonal contraceptives. What a lot of people don't know is that hormonal contraceptives actually protect our fertility, not the other way around. That is one. Number two, it's not as easy for us to conceive as we think it is. It seems that people just get pregnant. It isn't that easy. And that's because the window of opportunity for a woman to actually conceive is just 24 hours. That's how long her egg is viable. For a man's sperm, it's viable just for 72 hours. So you'll find when you ovulate every month, meaning during every menstrual cycle. So if you miss that window of opportunity, you have to wait.
Hours.
Yes, you have to wait for the next cycle. That's one. Number two, the first question I'd ask this lady, has she been to see a doctor? Because she's sitting back waiting.
Yeah,
she needs to actually, yes, she actually needs to go in and see a doctor. And the questions that we would ask are, first, does she have any other children? Does she have any children, sorry? Has she ever conceived? Two, was her cycle normal before she put in her implant? Number three, does she have regular unprotected intercourse with her partner? Because if her partner travels a lot, for example, because of work, or she travels a lot because of work, their opportunity for them to actually have intercourse and at the right time and for them to be able to conceive is missed. And then, of course, it takes two to make a baby. Has her partner, does he have children with another partner? And has he been to see a doctor to find out whether he does have a problem? Because when you take couples, you'll find that when it comes to issues of inability to conceive, 40% of the problem is usually due to the woman. 30 to 40% is usually due to the man, and in that remaining 10%, it's both. Okay, it's both. So you can't just assume
that it is you.
Yeah, that it is actually you. I think it's a cultural thing. It's actually a cultural thing.
If there's a problem for for this couple having a problem,
it's usually the woman.
Then it's usually the woman.
It's assumed that once the man ejaculates, then he doesn't have a problem.
Yeah,
yes.
She's supposed to get pregnant. That's interesting. I'm just sitting here thinking, 9 months later, how? I don't know if there's a language in your clinic you get the women to use to get the women to come with the men to your clinic so you can see them together.
What usually happens, more often than not, it's the woman who comes in first. And then you explain to her, we can examine you, but it's a lot easier if the two of you came in because it takes two to make a baby.
True.
That is number one. And number two, the test for the men, it's very, very simple. Once you've done a physical examination on him, then you send him for a semen analysis. The semen analysis tells us so much. It tells us whether he's producing sperm or not, if he's producing it in the right quantity, if the percentage of that sperm that he's producing is normal, if they're able to swim and swim in the right direction to be able to get to that egg and actually fertilize it. And then also the character of the semen, whether it liquefies or not, whether it has the right composition or not, whether there's infection or not. Yeah. Okay. So all those factors come into play. Now, when it comes to the lady, the investigations, it's a whole spectrum. We have to make sure, we do an ultrasound to make sure that the general anatomy is normal. We have to check to see whether the tubes are patent or not, because that is where fertilization takes place. We have to find out if she has an irregular cycle. We have to do a hormonal profile. So it takes a lot more for the woman.
Okay.
Yeah.
All right. Going into the second question. This is a question by Sharon. Her question is, I have a problem with my nipple. It is painful. Am I pregnant?
The only way you can actually tell if you're pregnant is by doing a pregnancy test, either a urine pregnancy test or a blood pregnancy test, and doing an ultrasound. And the ultrasound would be able to pick up the pregnancy usually after 5 to 6 weeks.
Okay.
Yeah.
So for her to rule out any other thing,
she just has to do a pregnancy test. Yeah.
All right, Sharon, if you're listening, you need to take a pregnancy test.
And ideally a blood pregnancy test.
It's more accurate.
Yeah, it's more accurate. Because we're actually measuring the level of the hormone that we test in urine in the blood, and that gives us a more accurate information. It's more specific, and it can actually tell you how many weeks into the pregnancy the woman is.
Okay. The third question, and it's a common question asked by women. I am looking to have a boy. So how, if I want to get a baby boy, are there particular days I need to have sex? What do I need to do to get a baby boy?
Frankly speaking, there's no formula, Christine. And women are sitting ducks. All our eggs are X. You know, when you actually come to the genetics, it's the men who determine the sex because they have X sperm and Y sperm. So if an X sperm fertilizes the egg, you'll get a girl because that's XX. When it's a Y sperm that fertilizes the female egg, which is X, you get XY, which is a boy. There's no formula.
So as a woman, you have no role whatsoever.
You have no rule whatsoever. We're just sitting ducks.
We go to the next question, Dr. Monda. Her name is Ruth, and she says her cycle is 21 days. When can she get pregnant?
The 7th day of her cycle, the first day of the cycle being the first day of her period. The average cycle is 28 days. So that is why you hear women saying that it's known that you get pregnant on the 14th day. But, that's when you're most likely able to get pregnant.
Right.
Because that's when you ovulate. But that's for a woman who has a 28-day cycle. Now, if you have a 21-day cycle, what people need to know is that it's only the second part of the menstrual cycle. That is the time after ovulation that is constant, a constant 14 days. The variation to our cycle comes from the first part of the cycle.
Okay.
So if she has a 21-day cycle, the most likely time for her to ovulate is on the 7th day.
On the 7th day?
On the 7th day, because you add 7 days, she ovulates, and then 14.
Right.
Okay? So that's how, for somebody like that, she'd have to count backwards.
Wow.
She'd actually have to count backwards to know her most fertile days.
But
to make it easy, by the way, what we usually do is tell patients there's so many apps that are good that can actually give you the most likely time for you to ovulate based on your cycle when you actually key it in. So it does the calculation for you.
Right. Okay. We have our first question from a gentleman, and the question from Robert is, for a man who doesn't produce sperm at all, what can be done?
One assumes, of course, that for him to have been told he's not producing sperm at all, he's been to see a doctor. So if it's a treatable course, we will treat. If it's a non-treatable course, then they have to go to a donor, a sperm bank,
right?
Which we do have in Kenya now.
Just to elaborate, Dr. Monda, what are the treatable,
like if they have infections. If they have infections.
What kind of infections?
STIs.
Right.
Yeah, they may have STIs. They may have an infection of the prostate gland, which contributes to the formation of the semen. They may have a blockage in the tubal system that actually carries the sperm. They may have a varicocele, which is something like a varicose vein in the testes.
Okay.
Yeah. Okay. So those are things that you actually can correct.
Okay. And then there's that you can't correct.
Yes. I mean, if he's not producing sperm, there's nothing you can do about it.
How common is it, by the way?
It's not as uncommon as we think.
Interesting.
One of the commonest causes is if a boy gets mumps and it goes to the testes. It knocks out those cells completely, the cells that actually produce the sperm.
It's funny you mentioned that because I know of a particular school, a friend of mine was mentioning that their school has a mumps outbreak. So then it would make me worry, for the boy child.
For the boy child,
in that
yes.
Class. I wonder how mumps look like. What are the signs and symptoms?
Usually fever, general malaise, and then you get a swelling of the parotid salivary glands.
Right.
Yeah.
Right. And
it's a viral infection. Yeah, it's a viral infection. Rarely really very severe.
Okay.
It's like having like chickenpox. In fact, chickenpox is more severe. It's a more severe infection.
Interesting. All right. We are going to ask a question now. Before we go to the break, we have a question from Ferdinand. And the question from Ferdinand, which is a recurring question actually, what causes miscarriages?
Okay. Now, the medical term for miscarriages is abortion. So that's what I would call a miscarriage, okay? Now, an abortion is a termination of a pregnancy before 20 weeks of pregnancy, which is the layman's 5 months, or before the fetus is 500 grams in weight and cannot survive outside the uterus. And there are different causes. It could be spontaneous or it could be induced. Now, when it comes to the spontaneous type of abortions or miscarriages, you may have a threatened abortion where the pregnancy is threatening to come out. You may have an inevitable abortion where regardless regardless of what you do, that pregnancy is going to come out. You can have a complete abortion where all the products of conception, the pregnancy and everything that surrounds it, comes out completely. Then you may have an incomplete abortion where you get some of the products of conception come out, but then some of it remains in the uterus, and that's when a woman's uterus has to be evacuated.
Right.
Then you may have a missed abortion where the pregnancy stops growing or dies, but then stays in the uterus. Okay, so you have to get medication or be taken to theatre to evacuate the uterus. Then we have septic abortions, which more often than not are induced abortions. The backstreet abortions. Yeah.
Okay.
Now, the causes are several. It may be chromosomal or genetic, where the woman gets pregnant, but remember, these are cells that are dividing rapidly. So something goes wrong. Okay, the coding goes wrong, and then you get an abnormal type of fetus, and it's expelled. Nature has a way of expelling. Yes, nature gets rid of abnormal fetuses that will not be able to survive outside the uterus.
Right.
Then we also have immunological diseases like connective tissue diseases, where the body actually rejects the pregnancy, and there are a lot of other factors that go into that. It could be infections, even just basic malaria. A febrile an illness that causes high fever can make you miscarry as well.
Really?
Yes, because of the process. It triggers the chemicals that trigger labor. So the pregnancy is terminated because of that. Or infections like rubella, like brucella, like toxoplasmosis. You may have an anatomical abnormalities of the uterus. You'll find like these women who have double uteruses, and that one you'll discover when you do, for example, an ultrasound. It may be the cause may be diseases that the mother may have, like certain heart diseases.
Right.
Thyroid gland disease, diabetes, the environment. It might be medication that she's on. For example, some drugs that we put patients on for epilepsy and for thyroid gland disease. It might be even just the environment. If she stays in a toxic environment where, for example, she lives next to an industry and they're discharging their effluent into the water. So and then substance abuse, medications, alcohol, cigarettes, particularly alcohol abuse, and abuse of hard drugs.
I hear you, Dr. Monda. We're going to take a short break.
Okay.
We are going to take a short break right now, and when we come back with Dr. Monda, we are going to take the second part of Ferdinand's question. Don't go anywhere. We have this question and others that I'm sure you're going to learn from. Welcome back to today's episode of Today's Parent, where we are having a Q&A with Dr. Monda, who's a gynecologist. Dr. Monda,
yes.
Before we went on the break, you had covered the question by Ferdinand, but there was a part B to that question when it was a question on miscarriages.
Yes.
What causes miscarriages? And the part B of that question is if miscarriages are curable.
They're preventable. In the sense that they're preventable, not curable, because it's not a permanent thing. It's not like having an infection like malaria and then you're given medication. So it depends on the course. Yeah, so it depends on the course, and when you find out and that is if a woman has had recurrent losses. Okay, there's something else I forgot to mention. By the way, sometimes the woman's ovaries will not produce enough progesterone. Progesterone is the hormone that maintains pregnancy. So when you have that, then when we think that is actually the problem, then we will give the woman progesterone in the next pregnancy to support it until we're sure the placenta now is able to produce the progesterone.
Right.
So that's another cause, and that's a treatable cause.
Okay.
Yeah.
Talking about curable, preventable, I know a lot of women, I don't know if it's a common thing, but I feel like I've done my own research. The first pregnancies, a lot of them, the first trimester, something happens, and they end up in miscarriages. I don't know if it's a fact or if it's not a fact. You can correct me if I'm wrong. But for somebody out there who then a miscarriage happens, and you're feeling of there's nothing I would have done, no matter what I would have, like you said, it could be an act of nature. If you can console, a woman out there who could be feeling guilty having had a miscarriage.
About 50 to 60% of the early pregnancy losses or miscarriages, or what I call abortions, are actually because of chromosomal abnormalities of the fetus. So it doesn't matter what you do. There's nothing you can do about it. And even what I have mentioned, we usually will put a woman on progesterone so that if it's a normal pregnancy, it will assist. If it's an abnormal pregnancy, it doesn't matter how much progesterone we give her, that pregnancy will still be expelled.
Right.
That's one. Two, a lot of times, a woman will have a delayed period and will not realize she's pregnant. And then she starts bleeding and she assumes it's actually a period. So a lot of women actually have miscarriages and they're not even aware that they're having a miscarriage. Wow. They just have a slightly heavier than normal period and assume, it's because my period delayed.
The next question is an interesting one, Dr. Monda. Mm-hmm. I'm a lover of tea. Can tea affect my chances of getting pregnant?
No, not at all. Not at all. One of the highest fertility, one of the highest fertility rates is in Western Province, and they drink a lot of tea. Yeah, they drink a lot of tea.
The answer is absolutely
no.
All right, let's move on to a question from Sarah. And Sarah's question is, I'm having a white discharge, but it's not smelling. I went to the hospital and was told it's a UTI. I was told it's a UTI. I'm confused. Please help. I think she's confused because it doesn't have a smell, but she's been told it's a UTI.
Okay.
Yeah.
Now, there's a lot of confusion between urinary tract infections and vaginal discharges.
Explain.
That's one. Two, when we're talking about urinary tract infections, we're talking about infections in the urinary system. There's no direct communication between the reproductive system, meaning the vagina, the uterus, the tubes, the ovaries, and the urinary system. They're just neighbors. So when we're talking about a urinary tract infection, we're talking about infection in the kidneys, in the bladder, and in the urethra. Okay? So, and there, the symptoms are completely different. You'll get pain when you're passing urine. If it's a very severe infection, you'll get pain when you're passing urine. You'll get frequency, meaning you have to go to the loo all the time. You'll have, and if it's a very severe infection, you'll get blood in the urine as well. And if it goes to the kidneys, then you develop things like fever, diarrhea, and vomiting. So that is now a urinary tract infection. Now, when it comes to a vaginal discharge, we need to know what is the difference between a normal vaginal discharge and an abnormal vaginal discharge, because the vagina is not dry. The commonest vaginal discharge we'll get is in the middle of our menstrual cycle, when the mucus plug becomes liquidy and is expelled. And that is usually mucoid. It may be egg white or yellow in color. It may have a bit of blood in it and there's no smell. Anything outside that is abnormal.
Okay.
So for her, that white discharge sounds more like candidiasis candida. Now, what a lot of people don't know is that our bodies are not sterile. We have organisms that live on the skin, in the mouth, in the large intestine, and for women in the vagina. Men don't have a vagina, so they don't tend to have the problems we have. And the two main organisms in the vagina are candida and bacteria. And in that group of bacteria, candida, by the way, is a relative of the yeast that we used to bake. So when it comes to the bacteria, there's a group of bacteria in that colony that lives normally in the vagina called Dodelane's bacilli or lactobacilli, similar to the bacteria that we use to make maziwa mala and yogurt. Now, what they do is that they convert a sugar that's found naturally in our vaginal cells called glycogen into lactic acid. That lactic acid serves two purposes. It keeps those organisms that live normally in the vagina below a certain level so that they don't cause symptoms. And then by creating an acidic environment in the vagina, the upper parts of the reproductive tract are protected because now infection-causing bacteria cannot actually colonize the vagina, ascend into the upper parts of the reproductive tract, cause infections that would block the tubes and cause problems like infertility or pelvic abscesses. Okay. So, but then sometimes the acidity in the vagina may drop. And when that happens, you'll find that either the candida or the bacteria or both will multiply and grow. So when it's the candida, you get this whitish discharge that looks like curdled milk and causes a lot of itching. If it's bacterial, you'll find it's a foul-smelling discharge, particularly thin, gray, and smells quite a bit when it's exposed to air or just after sexual intercourse or after your period. But more often than not, it's an overgrowth. Note I'm saying it's an overgrowth. It's not an infection. It's an overgrowth of both.
Okay.
Now, the acidity in the vagina may drop just before your period just after your period, around ovulation time, and it's standard during pregnancy. So that's when these organisms will multiply and grow and start causing symptoms. The acidity in the vagina will also drop when after sexual intercourse, because semen is alkaline, the vagina is acidic. You mix an acid and an alkaline, you'll find the acidity goes down.
Right.
After a course of antibiotics, because they knock out the good bacteria as well. So with less bacteria, you find the acidity. Also, the less lactic acid is produced. So you'll find that the organisms will multiply and grow as well. Even just hot weather. For example, if she went to the coast right now, the candida would actually multiply and grow and flare up, and it can be quite severe.
Because of the humidity?
Because of the humidity.
Right.
Remember, the genital area is warm and moist, okay? For some women, even just after use of latex condoms, you may find when they have an irregular cycle, women who have immunosuppressive diseases like anemia, diabetes, HIV. So we explain this to patients so that they understand it's not an infection, one. Two, it's not an STI. It's just an overgrowth of the organisms that live normally in the vagina. And what you do when you get an abnormal vaginal discharge, you just go and see your doctor. We examine, confirm it is candidiasis, and we treat.
Noted.
Yeah.
And it's good that you mentioned there's a big difference between an STI and a UTI.
Yes.
That's good to know.
Yeah.
Talking about STIs, that's the next question we have. Somebody is asking, how can I get pregnant if I'm living with an STI? Maybe you could also define at this point in time the difference between an STI and an STD, if at all there's a difference.
STI means sexually transmitted infection. STD means sexually transmitted disease. It's the same thing.
It sounds more serious than infection. I don't know.
Actually, I don't know, but the more current term is STI rather than STD. Yeah.
Why? Was there like some stigma around STD?
Yes.
Wow.
I think that was part of the problem.
Okay.
Yeah.
Okay.
But then medicine is very dynamic. You'll find that the other organisms, other infections that have been included in, in being called an STI when it's not a standard STI.
Right.
That's number one. Number two, I'd want to know, has she really been diagnosed to have an STI? And if she was, she should have been treated. Yeah. I would advise that whoever she is to actually go in and see a doctor. Because how does she know she has an STI? And which one? Because most of them are treatable, apart from infections like HIV, hepatitis B. Yeah.
So does it affect eventually, if at all, she has an STI?
If she has an STI, like chlamydia that I've mentioned, chlamydia and gonorrhea, and she doesn't get it treated, and it damages her organs in the pelvis, particularly the tubes, and she'll become infertile. Because once the tubes are blocked, you can't conceive naturally.
Okay.
Yeah.
Dr. Monda, touching on the question of STI, STDs, what's the effect on an unborn child, on the baby who's about to be born?
It really depends on the STI itself. So, for example, if it's something like syphilis, one, it causes congenital malformations. Okay.
Congenital malformations.
It causes congenital malformations, things like cleft palate, cleft lip. Yeah. And that is why it's one of the standard tests we do during pregnancy, because it's treatable. And it's very, very easy to treat. So that way the mother does not pass on the infection to the baby. The baby may also be born with congenital syphilis, but that is very, very rare. Now, when it comes to, we also do hepatitis B.
Right.
So that we make sure that we prevent mother-to-child transmission of the hepatitis B virus. And that is by giving the baby, we immunize the baby after the baby's born, and then go on and treat the mother the way we usually do. If it's HIV, of course, we'll give antiretrovirals to reduce the risks of the mother passing on the virus to the baby during delivery. When it comes to things like gonorrhea and chlamydia, the mother can actually pass on the infection to the baby during labor. But the commonest infection the baby comes out with is an eye infection, a conjunctivitis, which is very easy to treat.
Okay.
Yeah. But the dangerous ones, of course, are the ones that are passed on from the mother to the baby in utero and cause congenital malformations like syphilis.
I hear you. I'm just curious, when the new parents or a couple that is pregnant, they come to see you, is it standard practice for you to do the STI tests, or they need to give consent?
It's part of the antenatal profile. A part of the antenatal profile includes the syphilis test, which we call the VDRL. We check for hepatitis B and we check for HIV. And of course, you cannot send a patient for tests without their consent. Yeah. First of all, you have to explain what all the tests are and what you're looking for, and they have to consent. Yeah. So those are the standard 7. We will do their standard 7 tests or so that we usually do for the pregnant mother. Okay. And by the way, Christine, if she declines, there's nothing you can do about it. It's her right. But it's rare to come across a mother who will decline, because she understands it's for her benefit.
The well-being of her baby.
And it's for her benefit and for the well-being of her baby. What we do is, of course, the commonest worry is confidentiality, whether it'll get to the partner if they don't want it to happen, or to other people. That's usually the issue. It's usually about confidentiality.
Okay. All right. The last question. Last year, somebody's asking, last year I was a first-time mom, and I realized I was pregnant, and I started my clinic early. But in the process, I was told I'm not pregnant at the clinic. I moved from one hospital to another, and then on doing further tests, I realized I was carrying twins, and then had a miscarriage. What causes miscarriages?
Just like, yes. Christine, it's just exactly what I told you. A miscarriage, a medical term for a miscarriage is an abortion. And it's a termination of a pregnancy before 20 weeks or 5 months of pregnancy, or when the fetus is less than 500 milligrams and cannot survive outside the uterus. And then there are different causes, there are different types. She had one type of a miscarriage or an abortion called a missed abortion.
Right.
Yeah. She had a missed abortion where the pregnancy stopped growing. The fetus has died, but then the products of conception, that whole pregnancy was not expelled. It just remained in the uterus. So it is likely that when she was going to check, she knew she was pregnant, she had all the signs, probably had done a test earlier and it had turned out positive. But now when she went to start her antenatal visits, they must have done a pregnancy test and found it was negative. So eventually is when she may have gone, yes, definitely. She must have gone somewhere else where they probably did you do a blood pregnancy test to confirm if you're not very sure, and then you do an ultrasound, and then that is when you find she has a missed abortion.
Right.
Yeah.
Okay. Dr. Monda, we've come to the end of this segment. It was an awesome Q&A with you, and I'm sure to the parents who are watching, they've learned a lot from you.
Yeah. Thank you for having me.
Thank you for your time.
Okay.
And with that, we come to the end of today's episode of Today's Parent, where we had Dr. Monda, and we had a Q&A when it comes to matters reproductive health. You had a lot of questions when it comes to miscarriages. I hope now you are more informed and you are more aware. And in case of anything of importance, it's for you to see your doctor. When you have any concern, don't wait for too long. Make sure you set an appointment and see your doctor. Thank you for joining us for today's show. I have been your host, Christine Casina. We have been here in studio at Little Cribs, the home of exciting, affordable, and durable kids furniture. Please make sure you check them out on Facebook and on Instagram. If you're looking to find out what we have been up to on Today's Parent, you can find past episodes of Today's Parent on Switch TV, the YouTube channel. We look forward to having you next time. Stay tuned.